So I want to first start off by, thanks for the clapping hands. I want to start off by first giving an overview of the literature and what we already know about weight stigma in broader society, but also in healthcare specifically, which is the context that these studies are placed within, and then talk you through a couple experimental studies we ran, and go through the kind of implications and conclusions we drew from those, and hoping to have plenty of time for discussion at the end. So before I dive straight into healthcare, I think it's really important to get a good understanding of weight stigma in the broader society and the kind of assumptions and beliefs and stereotypes that really drive weight stigma. So there are three beliefs or assumptions that have been found to fuel weight stigma and also to legitimize it. So the first is this idea that individuals have a high level of control over how much they weigh, and usually this is thought to be something they can control through diet and exercise. So that kind of classic balance of energy consumption and energy expenditure. The second assumption is that weight is a reliable indicator of how healthy someone is. And we see this in many aspects of society, but particularly within the kind of language that's used around health and weight. So you may have come across the terms healthy and unhealthy weight before. Usually when people talk about a healthy weight, they're talking about a particular BMI category. So that's if you have a BMI between 18.5 and 24.9, you'd be classified as being a healthy weight, and anything sort of below or above that is classified as being unhealthy. But usually when people talk about an unhealthy weight, they're usually referring to someone who is over the healthy range, so someone who's in the overweight or the obese categories. And then the third belief is that weight stigma is a really effective tool for motivating people to change their behavior. And you can kind of see the first two assumptions feeding into this third one, where we assume that people who are higher weight are unhealthy. And there's also some stereotypes feeding into this around people being perceived as being quite lazy and lacking motivation. And there's the assumption that that weight stigma, stigmatizing them because of their weight, will provide them with that motivation to change their behavior and presumably to lose weight as a result. And we see these kind of beliefs pretty clearly, as I said, throughout many aspects of our lives. We see them in the news that we read, in the shows that we watch, and also in public health policy and campaign messages. And so these assumptions, as I sort of mentioned before, that they've led high weight people to become negatively stereotyped as having quite socially undesirable traits like being lazy, being overindulgent, lacking self-control. And the image on the slide there is, I don't know if anyone has seen this movie, it's from Secret Life of Pets. And I thought that this character was quite a nice example of how these stereotypes are kind of embedded within so much of the kind of media and the movies and shows that we see. So this character is a very overweight cat named Chloe, and in this particular scene she is trying to resist the urge to eat the chicken in the fridge, and she sort of repeatedly opens the fridge and looks at it and you know, kind of goes to eat it, and then, oh no, resist, close the fridge, then she's back again, she closes it, she's back again, and eventually she loses self-control and overindulges by eating the entire chicken in one go. So I'm sure it would come to no surprise to everyone in this kind of virtual room, that there are lots of negative effects of being exposed to any kind of stigma, and weight stigma is certainly no different. So researchers found that being exposed to weight stigma, or perceiving that one has been subjected to weight stigma, has been associated with reduced motivation to engage in healthy behaviours, reduced feelings of self-control, and reduced capacity to self-regulate food consumption, which then can lead to increase in food consumption, but also increased disordered eating, increased body dissatisfaction, stress, and psychological distress. So a whole array of negative health implications of being exposed to this kind of stigma. So how does this kind of look in the healthcare context? Well, research has found that health professionals tend to spend less time with their higher weight patients. They're less willing to treat those patients. They are more likely to fixate on weight loss, sometimes inappropriately. And they're more likely to blame the patient for failing to lose weight, rather than taking a closer look at what kind of treatment approach is being taken, what kind of methods the patient might be using to try to manage their weight, but perhaps more importantly, their health. And so, you know, just gone through all of the negative impacts that can happen if you're exposed to weight stigma. And so understandably, being kind of exposed to this kind of treatment can have a serious negative impact on the patient. It can be quite distressing, but it can also lead to them disengaging from healthcare services, which is sort of an additional negative effect that we really don't want to see. So coming into my PhD, I was reading all about this, and I found it to be quite alarming. You know, I thought health professionals would be somewhat immune to this sort of weight bias, and it's actually what led me to focus my PhD in this area. And coming straight out of my honours project, which drew quite heavily on the social identity approach and social norms, I wondered whether there might be something about being a health professional, something about that identity that might give us a better understanding of why weight stigma was influencing how health professionals treated their high weight patients. And also, kind of as I was reading the literature, I noticed that while much of the literature does recognize that weight stigma is attitudes that are held and influenced by society, they tended to, the research tended to conceptualize and operationalize weight stigma as individual attitudes, usually using some kind of anti-fat attitudes measure. And so I thought, well, are there factors that might be influencing how health professionals treat their high weight patients that isn't fully captured by these individual anti-fat measures? And the first thing we turned to was social norms. So previous research has found that social norms can influence prejudicial attitudes and discrimination intentions, where people are more likely to express prejudice or intentions to discriminate against members of a stigmatized group if they perceive that to be more normative among the sort of relevant groups in their lives, like their family or their friends. And so we thought perhaps this could be something that was important to look at within the healthcare context, looking at health professionals as a group. And so this led to our first research question: how do norms influence the way health professionals treat patients of different body sizes? And we also wanted to know if there was something different about health professionals who are health experts, if there was something different about them compared to sort of the general population. And so our second research question was how to normatively condone levels of weight stigma. and their influence on treatment recommendations differ between health professionals and lay people as the sort of comparison group. So to investigate these two questions, we conducted two experimental studies, one with practicing health professionals and the other with lay people. Both of these were done through MTurk. We got very similar samples, as you can see there, in terms of demographics, with the main key difference being their occupation. And the methodologies that we used were really similar. So I'm going to kind of present them together. So in both studies, we first made the social identity that we were interested in salient using the 4-item social identity measure. In the first study, this was the health professional identity, and then in the second one, it was we used American as the identity because it was an MTurk study. We then presented participants with a fictional patient's medical profile. This patient was seeking healthcare for 2 migraines that they had experienced in the last 12 months that they were concerned about. And the only difference between, we had 2 experimental conditions, it was between subjects, and the only difference between the 2 conditions was how much the patient weighed. So in one condition, the patient was shown to be an average weight based on BMI, and we communicated this using their weight but also a photo. And then in the second condition, the patient was shown to be having a BMI in the obese category, so they were a higher weight. And I'll show you what those profiles look like in a second. And so they saw one of these medical profiles, and then they were asked to make some treatment recommendations. What kind of treatment recommendations would you make for this patient? And then we asked them to complete a measure of weight stigma norms. So this was the average weight patient's medical profile. So you can see we had the chief complaint was where we had the presenting condition that the patient was seeking healthcare for, and then we changed weight, and we had a photo to communicate the weight of the patient. And then this was the higher weight patient. So everything is exactly the same except for their weight and the photo. So that was our IV, which condition they were assigned to. And then we used weight stigma norms as the moderator based on previous research that's found that norms can moderate the extent of bias. So we couldn't find a existing measure that was easily adaptable to what we needed. So we had to develop a measure ourselves and we did this based on the literature on weight stigma within healthcare specifically. So in the first study, participants were asked to indicate the percentage of health professionals that they believed would agree with each of the 7 statements that we presented them with. In the second study, it's the same measure, but we asked them to indicate the percentage of Americans that they thought would agree with each statement. And then the treatment recommendations was our DV. So this measure, basically what we did is we presented them with a list of 41 different possible recommendations they could make, and we asked them to select any and all that they thought were appropriate for treating this patient. Of those 41, 8 of them were deemed to be specific to treating someone for migraines and unrelated to weight. And 8 were deemed to be specific to treating someone for their weight and less so for their migraines. So that top one there is assessing their body fat percentage, finding out how much exercise they're engaging in, whereas the migraines was things like an eye test or a CT scan. And then the rest were just other recommendations that you could make that weren't deemed to be specific to migraines or weight. Okay, so what did we find? So in the first study, we found that overall health professionals seem to provide more treatment recommendations for the higher weight patient compared to the average weight patient. This is just in general. And when we have a closer look at the migraine and the weight specific recommendations, we can kind of see where this difference is happening. So for the migraine specific recommendations, we found that participants weren't treating the patients differently for their migraines. So there was no significant difference between the average weight and the high weight patient in terms of how many migraine recommendations were made. And that was quite good to see. It suggested that the health professionals were treating both patients evenly for their presenting condition. But then when we looked at the weight specific recommendations, we found that the high weight patient was receiving significantly more of these compared to the average weight patient. And so this kind of suggested to us that the high weight patient was getting treated for their weight as almost like a second presenting condition, in addition to their migraines, which is what they were seeking healthcare for. When we look at lay people in study 2, unlike health professionals, we didn't find any difference in terms of the total number of treatment recommendations based on patient weight. And again, we can kind of see why this is the case when we look at the migraine and weight specific recommendations. So for migraines, the average weight patient for some of these was getting significantly more of these recommendations made compared to the higher weight patient. And that suggested that the high weight patient was being treated a little bit less for their presenting condition. And we found the opposite when we look at the weight specific recommendations. So again, the high weight patient was getting, sorry, the high weight patient was getting significantly more of these weight specific recommendations made for them compared to the average weight patient. And obviously it's important to, keep in mind that these are not health experts in this second study. These are just your average person. So we wouldn't necessarily expect them to be doing exactly the same as the health experts. But what's really interesting is if you put the two graphs from the two samples side by side, looking at just their weight recommendations, you would be pretty hard pressed to distinguish which one was from the health expert and which one was from the lay people sample. And this is just all of them together to kind of give you an overall picture. So for health professionals, you can see that kind of weight being treated in addition to the migraines, whereas with the lay people, again, you can kind of see a bit of substitution going on here with for the high weight patient, more attention being given to their weight as opposed to migraines. Okay, so what about norms? We found that, well, we had expected to find an interaction because we thought weight stigma would moderate, but we didn't. We just found a main effect. So health professionals who perceived weight stigma to be more normative among their colleagues, they made significantly more weight specific recommendations for both patients, regardless of how much the patient weighed. And this was really interesting because it kind of suggested that perhaps there was a bit of kind of vigilance around weight going on here, where if weight stigma was seen to be more normative, their attention to weight was heightened, even if the patient wasn't actually by their BMI deemed to be an unhealthy weight. In the Laypeople sample, we did find the interaction we had expected, where the sort of differential treatment that we see for the high weight patient was just more pronounced when weight stigma was seen to be more normative among Americans. Okay, so just kind of summing everything up, we found evidence of bias among both health professionals and lay people. When treating higher weight patients, the health professionals appeared to treat weight in addition to migraines as kind of like a second presenting condition, whilst lay people appeared to treat weight at the expense of the migraines. In terms of norms, we found that weight stigma norms did influence treatment recommendations, but they did this differently in the two samples. So for health professionals, when weight stigma was perceived to be more normative, it seemed to increase health professionals' vigilance regarding weight for all of their patients, or for both patients. But for lay people, we saw the interaction that we had expected, which was that the differential treatment of high weight patients was more pronounced when weight stigma was perceived to be more normative. So thinking about kind of, okay, well, what are the implications of these findings? It is important to recognize that it could be best practice for health professionals to treat a patient for a secondary condition that they may not have come in seeking healthcare for. If they deem that to be a health issue, that could be considered best practice. Definitely some of the literature I've read certainly encourages health professionals to address weight for higher weight patients, even if the patient hasn't come in looking for weight management advice. And I've certainly read pieces that have talked about how health professionals don't actually do this enough. But it's important to kind of recognize that while this differential treatment could be considered best practice, receiving unsolicited medical advice around weight might be perceived as stigmatizing and discriminatory from the perspective of the patient. And this can, of course, have some serious negative effects on the patient's health and also their engagement with healthcare services. This sort of main effect of weight stigma norms that we found suggested that the sort of hypervigilance around weight among health professionals who perceived weight stigma to be more normative could be a little bit concerning, because patients who may be considered medically to be a healthy weight may also become targets of weight stigma and discrimination, and as a result may also experience some of these negative implications. So the kind of takeaway message is that health professionals really need to be aware of this bias and the fact that their good intentions may not always lead to good outcomes and may actually have some unintended consequences for their patients' health. That's all I had today. I just want to thank my supervisors and collaborators, Yolanda, Tegan, and Fee, and happy to take any questions.